How often do you get your period? How many days does it last? How many pads or tampons do you use? And is it painful?
Are there periods that are not painful?
Yes.
Where are they?
Right.
Can I talk to those species?
Your minds are blown, right?
Yeah.
Welcome to Broadlines,
A weekly video podcast by the Female Quotient.
where real headlines meet real conversations.
I'm Rae Williams, an entertainment, lifestyle, and culture journalist.
And I'm Natalie Lizarraga, journalist and news anchor. Today we're talking about something that nearly every woman listening has either experienced for herself or she's watched someone that she knows go through it.
And I'm going to start with a number, and the number is 7 because it's 7 years. And that's how long it takes the average woman to get diagnosed with endometriosis. So that's 7 years of pain and 7 years of being told, like, this is normal.
7 long years. Well, endometriosis, as a lot of us know, is not rare. It affects about 1 in 10 women worldwide. That's 190 million people. And it's one of the most common gynecological diseases on the planet. And most women don't know they have it because nobody told them that their pain was actually a symptom of that.
And then there's the bigger picture, which is that women are 66% more likely to be diagnosed than men, and 72% of women report being gaslit by their healthcare provider. And then in the ER, women actually wait an average of 65 minutes for pain medication versus 49 minutes for men.
It just seems like the system was not built for our bodies.
And today we're going to talk about how to try to operate within that system anyway. Our guest today trained at Harbor UCLA Medical Center, one of the most rigorous residency programs in the country, and then went on to serve as department chair at Good Samaritan Hospital before founding DTLA Gynecology in 2021, which is a boutique practice that she built specifically to give women the kind of individualized care that assembly line medicine cannot. So welcome, Dr. Yamaguchi, to the podcast.
Welcome, welcome, welcome. You're going to answer a lot of our questions, and we have plenty to ask you.
Excellent.
And I know a lot of women out there have these burning questions too. So
Well, burning is a very
burning is a very
Yeah,
pointed.
very funny.
We'll get to
Burning
those.
questions. We'll get to the burning. But most women are more likely to be misdiagnosed than men and wait longer for pain relief and more likely to be told that their symptoms are psychological. And as someone who's been inside this system for more than 20 years, how bad is it and where do you see some of this bias actually coming from?
You talk about just the definition of diagnosis, right? In the medical field, we've come up with these, we read these textbooks, we need all these criteria that you have to meet these certain criteria to get a certain diagnosis, right? But those diagnoses were based probably on male symptoms, right? So we're talking about like cardiovascular, all of those things, right? And so when you're talking about just, it's not necessarily a misdiagnosis per se because these women aren't meeting the criteria of the diagnosis, but that's because the diagnosis doesn't, those criteria don't fit the diagnosis. So I think it's a big problem, right? And then when it comes to women's health, I think a lot of times people get it in their head. They're like, oh, it's in my head, so therefore it's not real. But I'm like, I tell people all the time, I'm like, well, how's that depression going? It's all in your head. Are you telling me it's not real? Because they're like, I want that lab test. I want that study, right? I want to be diagnosed for sure with this. So why can't you do that? And I was like, well, how did that go with your therapist? Did you ask your therapist for that lab test for depression? And you're like, no, right? And it's because of the fact that I think people have forgotten that there is this mind-body connection, that so much comes from your brain, and that, brain things, just you can't discount something. Like for me, it's not a negative thing to say it's in your head. For me, it's just part of the diagnosis. And I think that's the problem, is that I think that, now people don't realize that, and then just the way that women, I think, and men talk about everything, right? Women come in and they say things to their doctor, to their provider, and they list symptoms. But men go in and are like, I want this fixed.
Yeah.
They say, this is a problem. And women are like, this is what's happening with me.
Yeah, that's true. One of the things we really want to talk about is endometriosis. I remember the first time I heard it from a friend who was like, this is what I got diagnosed with, but she had always been in pain. And it was a while ago. There wasn't really anything, nobody knew, right? It was just like she had really painful periods and other things. And then you find out, as we saw those numbers, is that 1 in 10 women are actually diagnosed with this. And it takes an average, though, of 7 years to get that diagnosis. I feel like, and you can correct me, but that seems like a very, very ridiculously long time.
It's a super long time. But then just think about it. When do you get diagnosed with endometriosis? Who's going to diagnose you? Your pediatrician, your internal medicine doctor? Who's going to ask you, right? When you go in for a 15-minute visit when you're 25 to your internal medicine doctor and they have to check your blood pressure, your cholesterol, your thyroid, your diabetes, do you think they have time to talk to you about is your period painful or not? right? And so part of it is just, providers are rushing through their care, right? So when you go to the gynecologist, in my mind, if it's a problem, talk to your primary care provider, but they don't understand women's health a lot of times. In my mind, that's why you go to a gynecologist and that's what people, are like, why am I going to a preventative well woman exam? Like, why am I going to do a well person exam?
Mm-hmm.
And it's because of exactly this, because, you don't realize it's a problem. You said it in passing, oh yeah, my period was painful, but because it never got brought up as an issue, your doctor, your provider, they can't deal with every single problem you have, right?
Right.
So they've prioritized it. And because a lot of women don't prioritize, they don't realize that's normal, or they don't realize it's abnormal.
Mm-hmm.
They don't prioritize it. And then it just gets put to the bottom of the list. And it's so, so bad because it's so easy, right? I just ask my patients, do you have pain? I ask them, everyone, new patient, how often do you get your period? How many days does it last? How many pads or tampons do you use? And is it painful? And if you make it part of the routine and they're like, it's normal, it's not that bad. I'm like, no. How many period pads do you use, right? And then they're like, well, yeah, my normal amount. My mom said it's 10. I was like, how long? Oh, 10 and 10 hours.
Yeah.
And they don't realize it's, and it's crazy, right? But they're like, well, right, well, my mom said it's normal. My mom said it's common, but not common and normal, right? Not the same. And people just miss it and they don't realize it's a problem. I think it's a huge problem.
Well, that's one of the things that I think, every time we talk about these medical things, the phrase normalization of pain comes up. And we are told that painful periods and bloating and exhaustion, that, like you said, that, people are kind of conditioned to feel like they're normalized. And when did that become kind of the standard diagnosis for pain? And then how do we know the difference between when something is actually a symptom of something or if it is just actually our bodies? Because obviously there is, most people do get some degree of discomfort or cramps, but how do you know when it's actually normal versus, what we've been conditioned to think is normal, which is dying every month?
I was going to say, are there periods that are not painful?
Yes.
Wow.
So this is the thing,
Incredible.
again.
Where are they?
Right?
Can I talk to those species? That's
So this
incredible.
is the thing, right? Common and normal, right? Common and normal are not the same,
Mm-hmm.
right? And I think that's what people forget is just because it happens to everybody else. Like if you cut yourself, it's common to bleed, right? It's normal, but you're probably still going to want to stop that if you cut yourself, right? And so I think that for me, if you don't know, it's not patients' jobs to know what's normal, what's not normal, right? That's the whole reason you go to seek healthcare is, you don't know. And we don't know, right? We don't always know. When I see patients with painful periods, I'll tell them we do this, it could be this, it could be this, but maybe it's not, right? We don't know. When I tell them, oh, try hormonal contraception, it's going to make your periods better. It should, but it doesn't always. Right. And so that's not, the whole job of a person is to not go and diagnose themselves. That's not your job, right? Your job is to go to a healthcare provider and say, this is what's going on. And that's what your healthcare provider's job is to figure out, is it normal? Is it not normal? Is it something that bothers you? Like I have a ton of patients who have painful periods and they don't want to do anything about it. They're like, no, I'm good, but because it's not that painful. It's only a little painful, right? Or they've tried things and they don't like the side effects and they're like, you know what, it's worth it. So, but it's just, I think in my mind, it's to recognize you're making that active decision. Like, I know I have painful periods. I know I have options, right, in order to treat them and I'm choosing not to. That's very different than being told like, oh, don't worry about it, suck it up.
Right. Yeah. My husband calls me Dr. Lizarraga because I'm the queen of the self-diagnosis. Out of thin air, I'll grab something and be like, that's what it is. One of the things that we talk about here too, and Rae has had this conversation with us a lot about fibroids, and they affect up to 70% of women, which is a lot. Again, these numbers are so high when it comes to things that a lot of women have. 70% of women by menopause and 26 million women here in the U.S., which is an enormous number. And yet women don't really understand, like, what are they? What is happening? Can you kind of break down for us in the simplified version of what fibroids actually are and what to do about them?
So fibroids are in your uterus. They're not the fibroadenomas you get in your breasts. They're not on your ovaries. They're in your uterus. And they're basically just one cell that multiplied as a tumor. So people freak out because they hear tumor. They think it's cancer. It's not cancer. It's just a growth. It's just a growth of one cell. It's like the muscle cell, basically. It's like this one part of the uterus that grows, and it grows into a mass and a ball. And it into itself is not dangerous. So it just depends on location and what it's doing. So you could, hemorrhage and lose a ton of blood with like a 3 millimeter fibroid if it's in your uterine cavity, like where you get your period. But I have people with fibroids like the size of my head who are outside, they're sitting outside the uterus and they're not causing any problem. And so, this is, I try and tell people like a fibroid does not need to be treated.
Yeah.
But what needs to be treated are the fact that your hemoglobin is half of what it's supposed to be, or that you can't have sex, or that you can't get pregnant, or you're having really bad cramping. There's so many reasons to treat it. And that really because what that does is it tells you how you need to treat it, because certain fibroids are treated different ways to give certain type of symptom relief.
I never actually knew what it was. Like, I know in essence, like, what fibroids are. Like, oh, I have fibroids, but I didn't actually know what they were until you defined it to me, which is interesting. As someone like living with them, you would think it'd be more common that most of us have them. We would actually know what they are. And what I was sharing with Natalie earlier is that my doctor actually, she got a little excited. It was really funny. She was like, "You have the perfect fibroids." And I was looking at her like,
Oh, 'cause
what
they're
does that even
round.
mean?
Oh, I know what she means. They're
She's
round.
very
She
excited
got
about
too.
that.
That's great. But she's like, not only are they that, but they are perfectly placed. So they're not interfering with anything. So like
Oh,
you
yeah,
said,
yeah.
that's one of the things that a lot of women don't know either, is just because you have them doesn't mean they're dangerous, but they could be if they're affecting your quality of life, which I think is another reason why it's important for us to actually discuss some of these things and discuss the symptoms, because it might be, I'm going to see if I say this right, but common to have
Right.
fibroids, but it's not normal if it's disrupting
Right.
your quality of life.
This is the thing. So before, when we first started getting ultrasounds, imaging, all those things, we used to think fibroids were bad.
Mm-hmm.
So people used to get their uteruses taken out, uterus and ovaries taken
Oh,
out. Like,
uterus.
oh, you have fibroids. We better do surgery. And you know
Oh
what?
my
They
gosh.
saved those people's lives, right? Because they kept on living. Look at that.
Oh, shoot.
And then it turned out they didn't need it at all. Like, you know what I'm saying? It turned out it was an unnecessary surgery. It was one of the most common surgeries performed in the United States.
PCOS just got renamed to polyendocrine metabolic ovarian syndrome, or PMOS. And I think it's one of the kind of most confusing, most misunderstood things that women hear about and go through. And there was a global consensus published that said the old name was misleading and actually contributing to misdiagnosis. And this is a condition that affects an estimated 1 in 8 women of reproductive age. So in your opinion, is this name change a good thing? And how does it help both practitioners and patients understand it?
I will say that I like it because, as I was telling one of my patients today, is that people get really confused. Apparently, I even clarified this for one of my patients today. So we hear polycystic ovarian syndrome, and when you had your ultrasound, they were not looking for cysts.
Oh, I thought that's what they were looking for up there.
So the term
So
the term polycystic ovary is the terminology. It's a description of a type of ovary that has many follicles.
Mhm.
When we're talking about cysts, a lot of times we're talking about larger structures,
Right.
which can be cancerous, non-cancer. We're talking about PCOS. We're actually looking for polycystic appearing ovaries. And there's a lot of controversy and discussion of what is it the number of total follicles? Is it the number of follicles in a cross-section? Is it their location? All these things. But it actually isn't looking for cysts. So cysts technically are a mass on the ovary that's more than 3 centimeters. We're not looking for that. We're looking for what we call a polycystic ovary. So it's kind of a misnomer to start with. So people are like, and I've done it to them. I'm doing an ultrasound to check for PCOS.
And I'm like, where are the cysts?
Yeah, and I'm like, look, you have polycystic ovaries. They come back in a year, like, don't you need an ultrasound to see if I need surgery on my cysts?
That's literally what I thought. See, and this is another number 2, living with a thing and you still don't even know what the thing is. Like, you know what I mean? It's so interesting how little we know.
Right? So I spend so much time talking to my patients about how they don't have cysts. But we know, like, there's this whole Rotterdam criteria thing that we use. So it's 2 of 3 criteria to meet the diagnosis of now PMOS, which I'm going to slip up, right? And so it's ultrasound findings of a polycystic ovary, not cyst, but polycystic ovary, talking about lab abnormalities showing elevated testosterone, or you're talking about like symptoms, like not getting your period, facial hair, acne, right? You only need 2 of 3. And then now they've broken it down into types of PMOS, right? So you can have elevated testosterone and irregular periods, but your ultrasound can be fine. You still meet the criteria for PMOS, and this is not new. It's just that I think people and even some providers, they get caught up. They hear cysts, right? And they get confused and patients get confused. And, for me, I have a little bit more time with my patients, but, I have to spend half the time telling them about the cysts that they don't have them.
Right.
It cuts into my time that I can talk
Right.
to them about the actual PMOS. But what I like about this new name is this whole polyendocrine metabolic ovarian syndrome, right? It really, because I always stress to my patients, it's about hormones. And people think, oh, hormones, testosterone and estrogen. I'm like, no, it's your hormones. It's a whole bunch of that at interplay. It's why you can be predisposed to diabetes. So by saying that it's this polyendocrine metabolic disorder, right, it ends up helping kind of have people understand that it is not just your ovaries. But that being said, it's still ovarian syndrome. So we're still talking about ovaries. It's still really important, And then I think it's also important to say it's a syndrome, not a disease. Or not like we talk about like diabetes, that's a disease.
Right.
Right.
Right? But a syndrome is a constellation of symptoms that kind of collect together. So that's why you can have some symptoms of PCOS, but not others, because it's a syndrome. We don't know why PCOS or PMOS. We don't know an etiology, right? With diabetes, we know it's insulin, all these things.
Right.
With PMOS, we don't have a cause. And so that's why we don't call it a disease. We call it a syndrome.
What is the treatment for it?
In general, you want to think about lowering the elevated testosterone levels. So, if I tell people, like, technically it's supposed to be diet and exercise, but we all know diet and exercise can only get us so far.
Right.
Right. And so, the mainstay is hormonal contraception. It's usually the first line. It suppresses your ovarian production of hormones, so it can normalize things. You can do things like spironolactone. You can do metformin in some cases. These GLP-1s are talking about maybe some things, but it's basically trying to get your metabolic system working correctly. And then, like, the better you are, then the better you'll be.
Wow, it's crazy how it's all connected to
Yeah.
your reproductive organs and also your metabolism. If you're on a GLP-1 or you're getting healthier or whatever it is, that's going to actually make your symptoms lower. That's so interesting.
And this is why it's hard to diagnose like PMOS in like adolescence. So, people will, because they're changing so much, if you measure hormones in a 16-year-old, they're going to be a little bit high.
Right.
So you can't use the same criteria, right?
What would you say is the most commonly misdiagnosed gynecological condition that you see in your practice?
Their PMS, their PMDD, but actual diagnosis, just because I do see a lot of patients who've been frustrated with their providers, is some of the atypical vaginitis, vaginosis symptoms are probably what I see a lot of, because but it's just a product of me seeing people that have kind of failed to get adequate diagnosis. So I do a lot of vaginitis because there's a lot of, we all know about the yeast and the BV, but there's a couple of other rare things. There's something called cytolytic vaginosis, which is controversial. There's something called aerobic vaginitis, which is a little controversial. There's all these other weird
Why are they
infections.
controversial?
They're hard to diagnose. Maybe aerobic vaginitis used to be controversial. It's like an overgrowth of, it's like an imbalance causing overgrowth of aerobic bacteria. And then, but it's a little bit difficult to diagnose. And there's this thing called cytolytic vaginosis because it's hard to diagnose.
So they were getting the wrong diagnosis.
They're getting
or
the wrong,
something like
yeah.
And then what are some of the other conditions that we are kind of, or you are kind of seeing that disproportionately affect women that are kind of getting less attention, or even that you think need more research funding or people need to look into more?
I mean, everything, I think, in women's health. I mean, I think that cardiovascular health, like the fact that me as a gynecologist knows very little about cardiovascular health tells you that probably more research should be done, considering how much women's health I do, right? There's not a lot of information that's very specific to women, and I feel like that's a big thing, right? For me as a gynecologist, but maybe this the current political climate, I feel like contraception is always a big deal, right? Whether it be male contraception, female contraception, but I feel like that always bears more information to make it more accessible, easier, lower risk, more successful. And I know that there's, current research in it, but I still think there's always... there's always room to grow.
Yeah.
Male contraception, it is in research and they're trying to make things happen. It is there's always talk about how there's side effects and like it's ridiculous because women deal with side effects all the time.
Yes. Oh my gosh.
And I think it's there, and I think there is a need for it. I think that men should be responsible for contraception as well.
Mhm.
But in my mind, it is not to replace female contraception because I do like the fact that women have control over
Yeah.
their own bodies. And I think it's important that men have control over their own bodies and they're held responsible for their bodies, right? I think also it would open up the conversation if men had to think about contraception and they're like, well, I have side effects. And you're like, yeah, welcome to my world, right? When my patients come in with their partners come in and they get to hold their hand for their IUD, they're like, oh, I'm getting a little dizzy. I'm like, you're not even naked.
I haven't doing anything. Like, even in a world where, there's male contraception, I just don't trust them. Don't, nope. Still
Them being
still
men.
right. Like, I just still would want, like you said, agency for myself, the ability to choose. I can obviously see the benefit in, some relationships, for example, but I just, in that, it just makes me so nervous because I'm just like you said, I don't want the agency to be taken away from women or us to have less options or us to still not be vigilant because at the end of the day, I still don't fully trust, especially with something, not the drug itself, but with the men's
Oh my
ability
gosh.
to actually
I took it
use
today.
properly.
I
Don't
know,
believe
right?
me? I'll show you. I
No,
took
I
it
have a
today.
headache.
I could just hear it now.
Or have you seen my birth control?
Yeah.
I can put an
Like
put an air tag on the birth control for the
Yeah.
man.
They're
in your
really
house.
like, I took yours. It's okay.
Right.
yeah,
Exactly.
they
Like, why's my
can-
birth control? Oh, I just took yours.
We have
Go
a
find mine.
whole ass purse with all our stuff. The number of times my husband's like,
Where's my keys in my wallet?
where's my keys in my wallet? I'm like, you have two things.
Two.
Two things. And you lose them every time we leave the house. I can't imagine having someone who needs to be responsible enough to take a pill. That's not going to get someone pregnant.
Yeah.
So
Well,
I'm sure the research is great, but also I think it's very telling that they're worried about side effects when everything that we take for our reproductive health has
Has a
some
side
sort of
effect,
side
right.
effect, and no one has said shit about that.
yeah. And some of the side effects are pain because the
Yeah.
IUD, pain and other side effects, but just pain to go in.
What does actual proactive gynecological care look like for someone?
I mean, I think it's finding the right provider, and it is hard. I understand healthcare is really expensive. And I think that, healthcare providers, especially physicians, are burning out
Mm-hmm.
because people are waiting so long to see their healthcare provider. When they see them, they're angry. Then their healthcare provider is angry because their patient doesn't like them. They don't like the patient. It sets up a little bit of an adversarial kind of thing.
Yeah.
I think that the most important thing is probably to be straightforward. And if you want something fixed, then ask your healthcare provider to fix it,
Mhm.
right? Because, a lot of times I have to really get stuff out of my patients in a very tricky way, and it shouldn't be that hard.
Yeah.
In order to get my patients to talk about perimenopause and menopause, I have a question: is your hair thinning? Because
Yeah.
people will say, yes, my hair is thinning, but they won't say I have perimenopausal or menopausal symptoms.
Mm.
So, and that's me trying to get them to tell me problems,
Right.
right? And I think when I talk to like my friends or my colleagues and they're talking to me about stuff, is they tell me, I'm like, walk me through. And they're like, well, I told my doctor that I have hot flashes and they didn't say anything, so it's not a problem, right?
Huh.
And I'm like, well, is it a problem for you?
I think it's just the way we've been conditioned. You know what I mean? I think it's a lot of, we've been told, again, like going back to the beginning, how these things are normal or everybody goes through it every once in a
Yeah.
while. And so when you come to the doctor, you're like, well, maybe I shouldn't even bother mention that because everybody has that, right? And I think that's something we need to get out of.
Yeah, I agree with you. What's one thing that you think that people or women might be skipping that they definitely should not be skipping when it comes to women's health?
I think seeing a gynecologist, people
Yeah.
are like, my primary care doctor does it. They said, I don't need to go. I heard you only need a PAP every 3 to 5 years. So I'm not going to go to my gynecologist because my primary care says they'll do it and that's going to save me money. Right now, there's like a big thing, which I think also frustrates people, and I see people posting about it, is that there's a difference between a preventative wellness exam and a problem-focused exam.
Mm.
So what happens that people have waited 4 months, 6 months, a year to see their provider, and they go in and they think they have like 2 hours of the doctor's time. And they're like, no, it's a wellness exam. And I'm like, and I have a whole thing. A wellness exam is just screening. It's not to say I don't want to talk to you about these things,
I see.
but your insurance is only going to cover a preventative exam. It's no out of pocket to you, no copay, but it does limit what we can talk about. It's not a full workup of everything.
Oh, wow.
It's screening. What do you need to get done next?
Ah.
Right? And so people try, but it's why can't you do it? They're so mean. They won't talk to me about anything else. They said I'm going to be charged more. And that's because your insurance has told us these are the things that we're going to cover in a preventative exam.
Wow.
Well, and they're, well, are you trying to prevent me from getting infertile? I was like, yes, but like that's not. You can come back. And so I think people just hear like we can't talk to you about it, and they don't realize that what I'm saying is I'm like, this is your visit to screen you for what you need done. Labs, ultrasounds, other imaging. You need to do this. You need to do that. You need to monitor this. That's where we figure out what the plan of attack is,
Yeah.
right? You just can't jump in. That's a wellness. You figure out what's
I
going
see.
on. You check in, see what the problems are,
Yeah.
and then you can pursue that full workup.
It's funny because I hear you and I feel like I was just there and she was like, you need imaging. And I was like, we ain't coming back for that. Can't you just do it right now? And she's like, no, you have to schedule me. So I have to come back again. I feel fine.
You see, and that's the problem.
If a woman is sitting in a doctor's office right now and she kind of knows that something is wrong, but her doctor is dismissing her, what can she actually do? What are the steps? What should she say besides switching providers? Because, sometimes that isn't possible. But what can she do in that moment?
I mean, I think that's really difficult. I mean, and this is part of what I think on the physician side we're all dealing with is like physician burnout. And so unfortunately, we know it's limited resources, right? A lot of patients can't switch providers. But, I mean, I think you just have to be direct and you have to ask, how do I fix this? Again, it's not because if you say, my twitching is bothering me, then that they can brush that off. If you say what is the cause of the twitching, they can give you a list. But that's not what you're asking,
Right.
right? You want it to be fixed. That is what it comes down to, right? So you are direct and you say, how can you fix this problem? And I think that's the key. And maybe they can help you and maybe not, because maybe they're stressed out. Maybe they're busy. It sounds like you have a really attentive provider who can pick up on these things and cares. But I do think that some people out there are just checking the box.
Yeah.
And they're just going to brush you off. Right? And again, we can always do more of a workup. As healthcare providers, we can do all this stuff. We can tell you all these things. But what I sometimes tell people, I was like, I don't know exactly what the cause is, but the important thing is that we fix it a lot of times, right? Make sure it's not going to kill you, and then you want it fixed. So if you're in their doctor's office, right, and you want to get it fixed, then you tell them, no, I want to get this fixed. I want this twitching to get better. I want my periods to be lighter. I want to be able to work when I have my period. I want to be able to sleep when I have my period, right? What can you do to fix it?
This is along those same lines, but what question should every woman be asking their OBGYN that most of them aren't asking?
What am I missing? Am I missing any part of my screening or anything? I think that'll give us a pause. I think that's a good question to ask, am I missing anything? But it also kind of depends on why you're going to the provider, I guess. But probably, is there anything that I am missing in my screening?
When is it time to like look in the mirror and be like, I need to find a new provider. I need to find someone else. When do you know that of like, this is not working?
Like if you have any doubt, then you should get a second opinion, right? I encourage my patients to get a second opinion all the time. I like beg them sometimes to get a second opinion because I'm like, maybe I'm hoping I'll have missed something and you can go and get a second opinion and they can tell me that I'm wrong, about whatever it is. So I think if there's any doubt, then ideally in an ideal world, you get a second opinion. But real world, like, financial constraints and all of that, you got to look, unfortunately, at your financial situation. And then you have to decide what you want to do. I think that a lot of people think that, my healthcare should be free. My healthcare should be cheap. I'm going to make it work. And I think that's fine and that's a choice. But if you are talking about making something a priority, right? If you really want to take care of an issue, one of my patients has said, the best gift that I can get to myself is my healthcare. If I'm going to splurge on something, it's going to be on my health. As opposed to that purse or those shoes, that's what I'm going to do because it's better worth to me. Yes. And I think that the problem is that people don't want to accept that because that's awful. That is awful, right? That healthcare has become so expensive that it's turned into a luxury good,
Yeah.
right? And that I think is a huge problem, which we won't even get into here.
Just had this conversation yesterday with my husband because he had some dental work done and they did this like in-depth numbing deep clean and he said it was $400 and I said, oh my God. And he goes, yeah, I'd rather have that done than buy something because this is my health. And he's like, I won't have to go back as many times. I won't spend in the end as much money. And I was like, I never thought it that way because we all think about it like this is costing me so much to go to the doctor. This is the first thing I think of is what is this copay? What is this bill going to be after I'm done? But if you think about it and reframe it as like it's the biggest investment that I can make, it makes a lot more sense. I'm actually more comfortable with that, saying it that way when I give them the money.
But I mean, I think it's horrible that healthcare has gone this way.
Of course.
But on the other hand, I have a boutique practice, right? But like, I think I save my patients money because my patients aren't going to urgent cares, ERs, right? They're not making appointments. Like when they have a problem, they can come in and instead of getting hospitalized for something later on or getting waiting, right? In the end, they're saving the money, right? Because I know the cheapest medication. I have the time to look up their random whatever it is, right?
Right.
I think what happens too is that a lot of women, when they can't afford the healthcare or they don't want to spend the money on the healthcare, and it's sometimes it's so much easier to be like, well, with this money, I can take a vacation and enjoy my life, as opposed to spending, $1,900 to take this tooth out. I'll just keep it till it has to come out, that kind of thing. And I think what happens is that they then turn to the internet to, especially for the smaller things that might not warrant a visit to the, a whole full visit to the doctor. You're like, I can survive this. And they get on TikTok. And that's sometimes, especially for, women stuff, that's the first stop. And I think some of it is helpful. Like I've learned quite a few tips and tricks that I think have been helpful to my life. But then there's the other side of it. And there's so much advice. There's the boric acid suppositories and hydrogen peroxide douches. I do not know who is putting hydrogen peroxide up their hoo-ha. I've never heard of that.
Okay.
One, but is it?
So you should not do that.
Don't do that, guys.
But
there's a but to this.
Boric acid I like for different things.
Yeah.
Hydrogen peroxide is used in very, very rare cases, but you would never need it without a doctor and a gynecologist.
Right. Well, this is people at home on TikTok.
You should never do that.
Like,
we do use it. I use it very rarely. I've had like 2 patients in my career use it.
Yeah. Wow. And then there's there's garlic for yeast infections, vaginal steaming. Like they have so many remedies and so many things. And what are you seeing come through your door in terms of even patients telling you like, yeah, I saw this on the internet? I'm sure you hear a lot of like, I saw this on the internet or I saw this on TikTok. And what's the line between what's harmless and what's like, please do not stick a, whatever object up there to get.
How do you do the vaginal steam on TikTok? Aren't there like rules for that?
They set up this. I've seen them because I'm not gonna lie, for a hot second I was like, wait, do I need to steam her?
Like
they like put the
not the content
down,
I'm looking for on TikTok.
Water. Then you stand over it and you just light your lady up.
What are people telling you at your office?
That is ridiculous. I mean, the steaming is one of them, which, well, here is the other thing. I take this all with a grain of salt. There is some crazy, right? That like, you're like, how could that happen? But then on the other hand, like maybe there's something you're missing, right? We all used to think that acupuncture was just a whole bunch of like crazy people, right? And so, as much as I like laugh and I'm like, that's probably a bad idea, like you do have to leave a little bit of room that maybe they're onto something, right? Who would have thought that cervical cancer was caused by a virus you got from, someone you had sex with, right?
Right.
So, but like the vaginal steaming or the garlic thing, that's like, those are the things that I like don't believe in. The boric acid I do like. I don't know if anything, my patients, I believe in a lot of kind of weird out there things. So I don't know that anything. So I don't know, but I don't know if there's anything really that crazy. Probably the garlic and the steaming.
Yeah.
So most of it is harmless, but not necessarily always helpful.
Right. And it can make things worse. Again, without the right diagnosis, it can, it can make things worse because no matter how much steam you put in your vagina, you're still going to have chlamydia.
Yeah. Oh, well.
Not funny for anyone who does have chlamydia.
Sorry to you.
The steam is not going to work. Okay, you have said that you want to avoid this assembly line medicine where you're just kind of checking off boxes. What does good gynecological care actually look like, and how do women go about finding it?
Someone accessible is someone who can do a wellness visit, who can really screen you because you're not supposed to know everything wrong with you, but can be proactive about your health, and so they can screen you for things. right? And I think that's really important. And being able to give you timely health care. And like this seems very standard. I mean, it is like what you think about, like, when I wanted to be a doctor, it's what I thought. I didn't think that it was going to be a problem for people to see me, right? And so I think that's the element. The biggest thing is being able to get a wellness exam and timely care. Those are the two things that I think are hallmarks of good care, but it's kind of impossible to find.
Yeah.
Right. And those are the big things. And then I will say the big problem right now is this whole rise in all this concierge medicine, this boutique care, all of this preventative care, is that it's also just ripe for abuse. Right. So now, well, it's, you're willing to pay a little bit. So, well, if you're really wealthy, you're willing to pay a lot. And how much are you really getting? Now it's turning into exploiting people because some people are willing to spend any amount of money. Right. And so that's where you have to walk this really fine line. Right. As a patient, you don't want to say, oh, I'm going to spend, $10,000 a month getting my care. I think it's the best because, you don't know. But then as a patient, I don't even know how you make that decision. Like what is good and what is bad. It's so hard.
What is the one women's health issue that you wish more people were talking about, just to close us out?
I mean, I think pain. I think pain is the big thing. Pain in whatever kind of way you're talking about, painful periods, pain with sex, right? Pain with anything. I think that's the big thing because it's so hard to describe. It's so hard to diagnose. It can be so hard to treat. So for me, I think that's like the biggest issue in women's health is pain. You can talk about mental pain, right? Depression, PMDD, right? Violence, right? Partner violence. All these things are types of pain. And pain is not something that you can see on a person. And so I think for me, that's like the biggest women's health issue.
Well, we have a little fill in the blank for you.
Okay.
If you don't mind.
Of course.
Okay, here we go. The symptom women dismiss most often that they absolutely should not is
Pain.
That's what I figured the answer was going to be.
The biggest myth about women's health that doctors are still repeating is
Periods are supposed to be painful.
I really am still flabbergasted that they're not supposed
people are
to
like
be.
sitting pretty. I'm like,
Like you
what?
just have your period and you have no painful symptoms
Yeah.
whatsoever. A woman knows something is wrong when.
When it bothers her.
The question every woman should ask her OBGYN that almost nobody does is,
Oh, I think it's weird. I talked about this. Am I missing anything? Am I missing any kind of workup or test? I think women aren't upfront when they go to their doctors because they're scared. And in my case, when they talk to me, they're naked.
true.
Right?
Naked and
I
scared.
mean, like, you take off your clothes and you put on some like gown, like you're not really in your right mind. Like I have a little sign. I created a little sign, even though some of my patients have seen me for like 15 years. That's like, you should undress, take off everything. It literally says like, take off your bra, take off your underwear, put this gown on and have it open in the back. And there's a little picture. And I thought it was a little condescending and my patients love it. Even though my patients who have seen me all the time because they're like, honestly, I always forget which way you want the gown on because I do want it on different.
I always said you always forget.
Right? And it's so because, and you know why? It's not like they're dumb people. They're just so flustered. Even the patients who have known me for years, you're so flustered when you take off your clothes in front of some person, right? Of course you're going to be scared to bring stuff up, even if you write it down and then it is a little awkward,
Yeah.
right? And especially with the providers who don't want to hear it or just rushing you through, like, come on, get through it. You're not going to stop and be like, hey, hold on, before you put that speculum in me, let me stop you with my legs open and ask you about my painful periods.
Yeah.
Right? It just, people are awkward. Like, one of the examples is, they laugh. I'm like, do you need any STI testing? I'll offer it to my patients. Like, why would I need STI testing? I'm married. Like, okay, well, do you need an STI testing?
Yeah.
And they're like,
Repeat the question.
I'll ask them about sex, right? Are you having any, are you sexually active? And they're like, yes, of course. They're like, I'm married. And I'm like, well, are you sexually active? Half the time they're like, oh yeah, you're right, I'm not. I'm like, here you were. And they laugh, right? And then I ask them, does that bother you? Right? I ask them, are you sexually active? So I try and ask a non-intimidating question or like a question they can laugh off, right?
Yeah.
And be like, are you sexually active? And then when they're like, no, then I ask them, does that bother you? Are you not having sex because it's painful? You're not having sex because your partner cheated on you? You're not having sex because you don't want it? You're not having sex because it's LA and Tinder's awful?
Yeah.
I don't know that struggle.
Well, asking more questions gets you to
Right.
the result as opposed to just brushing off the one and being like, let's move down the list.
Yeah.
If I could change one thing about how medicine treats women, it would be.
It would be, I think how we deal with women and how we provide healthcare, because I don't think it is the way that we deliver healthcare now is delivered in a way that's very male driven and it's not women driven.
How differently it would look if it was women driven.
I think it'd be more conversation, more talking, right? More not being gaslit, right? Because everybody wants a checklist. I mean, this whole world is male driven. It's all driven by metrics. Every part of this world is driven by metrics. You know, physicians are graded on metrics. Every job is graded on metrics. So healthcare is delivered by metrics. But, you know, women especially, we're not metrics, right? Look at the way that we try and deal with female libido. They tried to make it fit into metrics, tried to make it measurable, tried to fix it by fixing chemical numbers, and it doesn't work. And we don't know what drives the female libido, right? We know some of it's mental. So, you know, they have these drugs. They have Addy.
I was going to say, don't they have a pill for
They
women
do.
to take like they take it
every night.
daily, right?
So there's Addy, there's Vyleesi, and then there's a lot of talk now about testosterone. And those are things, but, you know, we can't even say we know 100% why all of those things work. And they don't work all the time. It's not like Addy is like, wow, you know, now you're suddenly going to have sex all the time. It's not like the Vyleesi, you inject yourself and it's going to be great for everybody. It's just so complex. And, you know, I think there is money behind it at this point. There didn't used to be. There's more resources behind it. But it's just so complex. It's just hard to figure out. And so, you know, I think that, you know, it's come farther, right? But it still has a long ways to go. And then there's the other side of it. Like I just had a person ask me, like, how much sex am I supposed to be having? Like, what's the standard number? Am I not having enough sex? Like my husband says I'm not having enough sex, but I'm happy. And so it's that whole thing of metrics, right?
Yeah.
The man wants to know, ask your doctor how many times a month you're supposed to be having sex. You know, there are people who are happy not having sex. And is that a problem? You know, is it bothering you? If it's not, then is it a problem?
Yeah.
It's so interesting that they're actually putting money behind that research.
I know, finally.
Yeah, and that there's like pills that you can take, but what would be like, what are the side effects of those? Obviously, it's just having libido, but if we don't understand it, wouldn't there be other side effects that maybe are not that? Do you know
Like
what I mean?
side effects in the medicine?
Yeah, from the
Oh, yeah, there's
medicine.
side effects of the medicine too. I mean, you know, whether it be you know, for Addy, you can't mix with alcohol. For testosterone, you know, you better, if you use high doses, you better, you know, have a good wax person or a laser or something like
Wow.
that.
Wow.
All of this just
You could
to
just drink the
say,
alcohol to
right,
fix the
that's what I was
libido
thinking.
sometimes.
Or you could just say F off, I guess. If,
I
like,
mean, yeah,
that's what you
well,
want that
nothing
day.
can give you anything if you have the ick. If you have the
Well,
ick,
there's no medicine for the ick?
No, there's no medicine
Get a new
for the
man.
ick.
Get a new
And then
man.
alcohol, it does mess with estrogen.
Oh, wow. Okay.
It does.
Yes, that's why I know it's like a whole thing. Your minds are blown, right?
Yes.
I've learned quite a bit. There are so many things I know we want to ask. And I think the biggest takeaway for me is just the difference between you saying, I have something going on and this bothers me. How can we fix it? I think that's a game changer, even personally for healthcare, to say that this is what's bothering me and not being like, well, I have a thing, and, you know, kind of leaving it to be like, well, that's normal. I think if we took that agency for ourselves and we were able to communicate that better, it would help both the providers be able to say, okay, I know exactly where I'm heading, and help women to feel more seen and heard.
I think my takeaway is just having these conversations, being more open, and having them with your friends, and just like you said, like putting the underwear. So like, there's no shame in this. We all have to go to the doctor. These are our bodies, and the more we know, the better off we are. So, like you said, directly talking to your doctor, as Rae said, is just like, it should seem logical, but we live in a world where it's like we're too afraid to say anything, or we don't feel comfortable saying something. So I think just having these open conversations is such a big thing that we need to continue to do.
Don't let fear get to you.
Yeah. Yeah.
Right? Don't let fear get to you, and, you know, be willing to be that person who's like out there and ridiculous. And you know what? No shame. Like,
Yeah.
have no shame, right? It's your body. What do you have the downside for? So what? Let them judge you.
Yeah. No
Like-
shame is a good one.
Because they can't tell.
They can't
All right,
tell.
tell everybody. All right. Thank you so much, Dr. Yamaguchi, for being here and for spending so much of your years actually doing the work and listening to patients. And I know it shouldn't be revolutionary for a doctor to be a good doctor, but it does matter. And so you can find Dr. Yamaguchi at DTLA Gynecology and on on Instagram at DTLA_GYN, where she's always breaking down all of the information that we talked about today.
Yeah, and if you guys listen to this and you feel seen, or maybe there's like you have questions, always reach out to us, of course. Send it to a friend who you think has maybe been dismissed by a doctor. Re-listen to it in your spare time before you pull up to the gynecologist so you remember exactly what to say. And your body, obviously, we just mentioned this, but it's like worth fighting for these things that you might say, like we said, common versus normal are very totally different things. We're going to be here every Tuesday to have more conversations just like this. But Dr. Yamaguchi, thank you as always.
Appreciate
Thank you very much.
Thanks for tuning into this week's episode of Broadlines.
A production of the Female Quotient, filmed in Los Angeles.
If you like this episode, and I know you did, make sure to rate, review, and subscribe.
If you have a question, maybe a work question, or you have an idea for an episode,
DM us at Female Quotient or leave a comment to get the conversation started.
hit that follow button while you're there.
See you next week.